Good morning, everybody. I'm Dr. Karunya, Associate Professor from the Department of Radiology in Sri Lakshmi Institute of Medical Sciences. Today, we'll be talking about lung metastasis. The lungs are the most common size of metastasis for non-pulmonary malignancies, since it functions as the primary capillary filter of venous drainage for most of the organs. It is usually scattered in the lung parenchyma or pleura and often infiltrate the adjacent structures. The most common primary sites are breast, colon, kidney, uterus, head and neck. Pulmonary metastasis presents with wide spectrum of radiological findings. The first one is cavitation. Although cavitation in pulmonary metastasis is not as frequent as it is in primary tumor, metastasis should always be considered in the differential diagnosis of multiple cavitatory lesions. The percentage of cavitation is approximately 4% in contrast to 9% in primary cancers. Squamous cell carcinomas are the most common type of cavitating metastasis, which accounts for about 70% of the cases. The head, neck, and urogenital systems are the most common primary organ sites. Chemotherapy is also known to induce cavitation. Would you like to describe this? Yes, it is a thick-walled cavitatory lesion. In this case, we can see that there are multiple metastatic cavitatory lesions in both the lung fields as the arrow shows. Metastatic sarcomas can also cavitate and result in pneumothorax, present as multiple cystic lesions. They resemble bullae and may have extremely thin walls. Bullae-like lesions on CT in patients with known sarcoma should be interpreted with particular caution. Chest radiograph obtained before chemotherapy shows multiple masses in both lung fields. You can see that there are multiple mass-like lesions in bilateral lung fields here in the right, left, in the left lower zones. Note the small eccentric cavitation depicted by arrowhead on the left upper lung field. This is again a chest radiograph obtained after 2 cycles of chemotherapy. It shows extensive cavitation of nodules with air fluid levels, as we can see here. Bilateral cavitation with air fluid levels. Note the irregular thickening of the cavity wall. We can see that it is of irregular thickening here. Multiple metastatic nodules in bilateral lung fields. They have both cavitatory as well as non-cavitatory nodules with irregular walls in bilateral, predominantly in bilateral lower lobes, the posterior segments of bilateral lower lobes. Here, this is a thin-walled air-containing lesion. We can see it in both lung fields. I don't think you can appreciate it well in the left one, but the right lung field is clearer. This is again a similar image which shows a thin-walled cavitatory lesion in the right lung field. You can see it also in the left lung fields here. Generally, calcification of pulmonary nodule is suggestive of benignity, as it is seen in granuloma or hematoma. But calcification or ossification can also occur in metastatic nodules from osteosarcoma or chondrosarcoma. Metastatic nodules from synovial sarcoma, giant cell tumor of the bone, and carcinomas of the colon, ovary, and thyroid may calcify. Calcification can also be seen in treated metastatic choriocarcinoma, Multifocal calcifications are unusual in metastatic disease except for those from osteosarcoma and chondrosarcoma. We can see here that there is a well-defined nodular lesion in bilateral lung field, one in the right upper zone and one in the left middle zone. There is subtle calcified foci in both these lesions. It is clearly seen in the CT here, as we can see that it has multiple tiny calcified specks. There are several mechanisms which are responsible for calcification. CT can't differentiate calcification or ossification in metastatic nodules, but multiple calcified nodules may be a sign of metastasis. Coming to hemorrhage. Hemorrhagic metastatic lesions can be depicted on CT. Fragility of neovascular tissue leading to rupture of vessels is considered the cause of hemorrhage. Peripheral hemorrhage causes surrounding ground glass attenuation, which is termed as the halo sign. This is a frontal chest radiograph which shows multiple ill-defined nodular and patchy attenuation in bilateral lung fields. Hemorrhagic metastasis in a patient with osteosarcoma. We can see that there is a lesion with surrounding ground glass opacities. These are multiple lesions and are seen in bilateral lung fields. CT shows ground glass attenuation around the nodules. Angiosarcoma and choriocarcinoma are the most common causes of hemorrhagic metastasis. Ground glass opacity, however, is not a specific finding and is also seen in other conditions like invasive aspergillosis, candidiasis, vaginal granulomatosis, tuberculomas, etc. The next entity is airspace patterns. Metastasis from adenocarcinoma may spread into the lung along the intact alveolar walls, similar to bronchoalveolar carcinoma. The radiological features of this tumor growth pattern can mimic pneumonia. Adenocarcinoma from the breast and ovary can also show this pattern of metastasis. This is a chest radiograph which shows airspace consolidation with air bronchograms in right upper lobe. We can see it clearly here. Almost the rest of the lung fields are normal. The cardia is also normal. No obvious bony abnormalities in this X-ray. CT shows consolidation in the right upper lobe with surrounding ground glass opacity and air bronchogram. We can see it depicted here with the arrow mark. Coming to the endobronchial metastasis. Endobronchial metastasis from extrathoracic tumors are rarely seen. The frequency varies from 2% to 28%. The common source of endobronchial metastasis are kidney, breast, colorectal carcinomas. There are two mechanisms causing endobronchial metastasis. First is direct invasion of the bronchial wall by means of aspiration of tumor, lymphatic spread, or hematogenous metastasis to the bronchial wall. Second is when tumor cells in the nose or lung parenchyma surrounding the bronchus grow along the bronchial tree. The most common radiological appearance is an atelectasis. In CT, a round bronchial lesion may be seen along with atelectasis of corresponding lobe. In many cases, differentiation between primary bronchogenic carcinoma and an endobronchial metastasis is very difficult. consecutive CT scans show an endobronchial mass, which is depicted by the black arrow here, in the superior segment of right lower lobe. Atelectasis and mucus-filled basal segment bronchi in the soft tissue and lung window is seen here. CT scan shows finger-like appearance in right lower lobe due to endobronchial metastasis. This is a CECT image at the level of carena, shows endobronchial mass, which is depicted by the arrowhead in the orifice of left upper lobar bronchus with collapse of left upper lobe. The mass is shown in the arrowhead. The collapsed left upper lobe is shown as the arrow. Then moving on to solitary metastasis. When a solitary pulmonary nodule is detected in a patient with extrathoracic malignancy, the probability of metastasis is approximately 25%. The most frequent malignancies include melanoma, sarcoma, carcinoma of colon, breast, kidney, bladder, and testis. This CT scan shows a solitary nodule in the left upper lobe, and it is confirmed to be a metastasis by transthoracic needle biopsy. Thank you. If you have any doubts, kindly let me know.